Hello and welcome to the NCS podcast. I'm your host, Dr. Nicholas Morris from the University of Maryland Shock Trauma Hospital. Before we begin, please note that the views and opinions expressed in this podcast are solely those of the host and guest and do not necessarily reflect the official opinions or positions of the Neurocritical Care Society. Having gotten that formality out of the way, I am really excited about today's guest. Today, we're lucky enough to have Dr. Chere Chase-Gregory, who is a neurointensivist credited as the founding member of the Women in Neurocritical Care Committee, which later became the Inclusion in Neurocritical Care Committee. And she's also a leading healthcare executive at Novant Health in North Carolina, where she serves as a senior vice president and chief health equity officer. She's adjunct faculty at University of North Carolina, where she developed a health equity curriculum designed to equip future physicians with strategies to address clinical and social needs through data-driven and patient-centered care. She's also a practicing neurointensivist, and how she juggles all of that, I have no idea. I'm waiting to find out. Dr. Gregory, thank you so much for joining us on the podcast.
Thank you. Really glad to be here.
Well, listen, I would love to maybe take this back a little bit sort of to your origins. So I read a little bit, you grew up in North Carolina, you actually trained here in Baltimore where I am, and I'm wondering how your early experiences really informed your decision to go into neurocritical care and to be such a passionate advocate for health equity.
Actually, it's kind of an interesting story. I always reference my roots in the South because I was raised by my mother and grandmother who were born and raised in Harrisville, North Carolina, which is a very small rural community here in North Carolina. So I say I'm the best from both worlds because I actually was born and raised in Newark, New Jersey with those Southern roots. And one of the things that really impacted how I saw life in general and medicine was whether you were in the inner city or whether you were in rural areas, there were challenges that people faced for just getting the everyday daily needs, whether it was education, nutrition, transportation. And so I think those experiences really, as a child and then growing up as an adult, and caring for people in my family helped me to understand how important it is to have access to healthcare. I think in most of the major cities where we train, we often take that for granted that it exists, but that isn't necessarily true for everyone in North Carolina or in the country.
Yeah, I'm wondering in your fellowship, so you were here at Johns Hopkins in Baltimore, and certainly we are an urban center with no shortage of hospitals, and yet I know in my practice, I take care of a lot of patients who haven't had much interaction in the healthcare system at all, despite sort of the overabundance of healthcare available here. Can you think back in your fellowship, kind of what were some of your experiences that really caught your attention? And, we also deal with we are the major care center for very rural areas of Maryland. What was it like taking care of people who really, despite all of the resources here, didn't seem to have a great way to access them?
It's funny, it goes a little bit back before fellowship when I was a student at the University of Maryland for medical school. I remember the aha moment for me. I had a 2-year-old who had been diagnosed with asthma, who had 3 siblings, all boys, 2 of which also had asthma, and their mom was unsheltered. I had the privilege of being a medical student, so I had one patient for the day.
Mm.
One, right? So I got to work on
Remember those
trying to
days?
find, remember those days? I had the opportunity to work on trying to find a shelter for her and her family that was smoke-free at the time. We won't talk about how
Mm.
many decades ago that was. Maybe it exists today, but it didn't exist then. And it was all consuming. And the idea of discharging this family without a home was just heartbreaking. And I think when you see that in your practice, it didn't change some years later after medical school. We won't talk about how many. I'm in fellowship now, and you still have very similar experiences where you've done all of the work that it takes to save someone's life. And when they get ready for discharge, 80% of whether or not they'll come back and whether or not they do well has everything to do with those sort of upstream drivers of health, or what people sometimes call social drivers of health. And only 20% of their outcome really has anything to do with all that hard work and compassionate care that we provide in the inpatient setting. So very early in my career, I made the decision to leave the neuro ICU on weekends and go into the community to try to educate people about their health outcomes, which was the health literacy piece. But it still didn't solve a lot of those social drivers of health that people now think of as upstream drivers of health. What can we do to help people be in the best position to attain that highest level of wellness and health?
Yeah, that's fascinating. Can you walk us through that a little bit more? What do you mean exactly? You went into the community and kind of taught health literacy. I think a lot of us have, grand ideas of doing this, but we don't know where to get started.
Well, and neither did I at the time. So I remember when I made the decision in my career. I had a 19-year-old Winston-Salem State student who had a massive left MCA stroke as a result of undetected heart disease, despite the fact that he had a family history. His mother had died very young from heart disease as well. And I remember saying, I can stand here and wait for patients to come, but this didn't help him and it won't help others in the future. And so some of it is just volunteering. So it can be church groups, it can be work groups. If you're not sure, you can look into some of the community partners. American Heart Association often has programs where you can get out and actually just spend a little bit of time in the community educating. We have team members that work in food banks. So if you're very interested in addressing some of the challenges that the community faces, you can be partnered with community partners that address transportation or address food insecurity. So there's lots of little ways to do it. As a leader, I partnered with the American Heart Association. At the time, they had several sort of turnkey kits. So you're a busy doc. You don't necessarily have time to create your whole curriculum for community education, but there are a lot of curriculums out there that you can use with across all populations, and you can just sort of turnkey and go and start sharing in the community. It's health literacy and then all of those things like food and housing and transportation. You're not going to be able to solve the problems of the world. I feel like you have to start there. Know that you can't, but I think one person at a time is helpful. One congregation or one community at a time is a great first step.
That's great. I definitely want to dig into that later, but I want to sort of hold on to that and ask you sort of maybe a surprising question, maybe not, but most of my colleagues are friends from medical school who were really passionate about these things. They ended up going into primary care or somewhere where they felt like they were closer to these social determinants of health and not seeing the end result like we do in the neuro ICU often. I'm wondering, what drove you to choose neurocritical care as your selected subspecialty as you navigate all these major issues out in the world that lead patients to our ICUs.
So first, what drove me to neurocritical care? I was a resident at Case Western University Reserve and at university hospitals, and Dr. Jose Suarez was a neurointensivist there at the time. And if anyone's met him, you know that he's incredibly passionate about educating young professionals. It's really hard not to be in his space and not want to be a neurocritical care doctor. So I did not know that going into residency, but it became very clear during my residency that we had the opportunity to take care of really sick patients, great outcomes. It was at a time when neurocritical care was really coming into its own in terms of the things that we could provide. In my early career at Novant Health, I was also responsible for building all the outpatient practices for neurology. So I had the opportunity, maybe unique to some neurointensivists, of seeing patients in the outpatient setting as well.
Hmm.
And that's where, there's two different struggles. There's a struggle to survive and live when you have that major impact of something critical. But then there's the struggle to survive and live in the outpatient setting. So you discharge a patient to the challenges that they face outside of the medical venues of care. So I think that's probably where I was inspired most, is seeing the what we often think of the before and after. So sometimes in neuro ICU you get Christmas cards and postcards saying thank you and how well we've done. But when you're an outpatient doctor, you also get to see what it means to be one of those 4+ million people who are now struggling with a disability as a result of stroke. And how do they manage their communities and still remain healthy? And that was my inspiration for getting out into the community and having more focus around those things that impact the outcomes for our patients that we don't always feel like we have control over in
Right,
the
right.
inpatient setting.
No, that's such a wonderful testament for post-ICU neuro recovery clinics, and we have a lot of people in the society that are working very hard to institute those both at their institutions and then come up with some sort of platform or framework that we can share across the society to help establish these. And it sounds like you've been doing that type of work for a very long time.
Yes. And I think for some of my colleagues who work in the stroke space, we create sort of bridging clinics or transition care clinics where we have the opportunity to slow down a little bit and ask some more questions around what some of their challenges are. So there may be an opportunity as people are building these programs to figure out and be innovative. And I have a team of about 60 social work intern students who are learning and growing to be social workers and other allied professionals. And it doesn't always have to cost as much as you think to have someone take the time to ask those important questions.
Right, right. Okay, we're going to get to some of those important questions soon, but part of what we're trying to do on this podcast is sort of get down on recording some of the history of the Neurocritical Care Society. And I've heard some stories about the Women in Neurocritical Care group and where that started from, but I've never heard it from you. And so, and I don't think many of our listeners might know the origin stories of the Women in Neurocritical Care group. Can you share that with listeners?
Absolutely. So throughout a career in neurosciences, at least I'll speak for myself, I was blessed with tremendous mentors, many of whom were men that without whom I wouldn't have the career that I have today. That said, I also think that very often because we're busy professionals, we don't get to connect with other women in neurocritical care. And so you may be in any particular facility or healthcare system, you don't get a chance to see other women. And I think women do have unique experiences in training and in their professional growth throughout their career. So I think it's a yes and. I actually mentor just as many men as I do women. I also think it was important to have a space where women who are in training and then getting launched into the world, and maybe once again, the only woman in that space, to have that network and that connection. I decided during my fellowship that that would be important. So, as a clinical instructor, so your second year in fellowship, I had an opportunity to have young and up and coming neurocritical care physicians who were junior to me, and I thought it would just be a great idea to create it in that space. I wish I could lie and say I knew that it was going to become much bigger than that, but at the moment, it was just to solve that opportunity for networking at Johns Hopkins among women who were in neurocritical care. And then the word just spread. It became something that people looked forward to, that connection and that networking, even understanding where do I go next. I had done that for many years. I actually work with a woman who leads neurocritical care in our Charlotte Presbyterian Hospital at Novant Health, who I met when she was a medical student. And I actually never met her in person. We met by phone for years. And then one day she came and worked at Novana. We laughed when we finally saw each other in person. It was that networking that guided her along the way. And so it's really fulfilling for the person who is the mentor. I believe it's helpful for the person who is the mentee. And that's really where it came. And then I love the fact that we've been more inclusive in our language now. I think it evolves over time. And it reflects what's been my general practice as an executive. I've always supported men and women who wanted to be neurointensivists or neurologists in different areas. And I think it's important that sometimes we just push the pause button. We're super busy in our clinical work and providing excellent care, that we network and focus on our own professional development. And that's a big piece of that work is how do we grow to be leaders? Even if you don't have a leadership title, As soon as you walk on the floor, you are leading for the day. And that's sometimes hard for people to understand that many of us go from high school to college to medical school and out to practice. And you get your first real job, and no one's ever created a system of teaching you how to grow as a professional and how to grow as a leader.
Right. Well, first of all, I want to thank you. I'm a member of the Inclusion Neurocritical Care Committee, and it's been such an important part of my career. And so, I kind of trace back our roots to you. You're the founder of this, so thank you so much. And the way it's grown, and especially now that we're kind of rolling out the Herd Foundation, which, for those who don't know, should know that in honor of Galen Henderson, we've started a research fund for health equity research and neurocritical care. And that all started with your work at Johns Hopkins and getting some people together for dinners regularly to share stories and for mentorship. So thank you so much for that.
Thank you.
I wanted to talk a little bit, sort of in this idea of mentorship and the way that we don't necessarily prepare people for, as you said, when you walk on that unit as the attending, there's really one leader and all eyes are on them. And so it's really our job when we do that to bring forward these important ideas of social determinants of health and health equity. But it can be so challenging to do that when we're focused on all of the, little management decisions that come up during the day. Is the Foley ready to come out? What's the blood pressure, et cetera? So maybe if you could offer some practical advice for those of us who have trainees and we want to make sure that they're getting this education. Where do you find time to do this on rounds? How do you work it into your discussions? And yeah, maybe we could start there.
And so we often talk about interdisciplinary rounds and how we think about the whole patient. And so one of the things that I would invite my colleagues to do is to think about, are there consistent rounds today where you might be able to fold in the conversation around what does this patient face when they leave the ICU, leave the regular units and then or general units and then go back home. Sometimes people always feel like that's the job. As a neurointensivist early in my career, I honestly thought that's the job of the floor team, right?
Hmm. Hmm.
But sometimes what happens is when people are critically ill, there are more components to the families that are there and present. Then as they get better, some of those things begin to disappear in terms of insights and opportunities. And some of those resources take a really long time to create. So if you are applying for Medicaid for someone or disability, all of these things take time. So starting earlier rather than later. I would tell anyone who is interested in doing this that it takes a village. You cannot do that as that single individual physician or advanced practice provider. So I would understand your system. Do you have social workers, case managers? Community health workers are often now a part of healthcare systems. All the community health workers for Novant that provide community health management actually report up to my team. So I would look at the resources for supportive care, and you can just start one patient at a time, building it into your everyday routine in terms of how you round. Academic medical centers are a perfect opportunity for this. So you get the medical student who has two patients, that might be the person who has the opportunity to gather the information and then connect them to the internal or external resources. If you're not in an academic center, which I am not, most of the time those resources are incredibly well versed in understanding what the resources are in the community. Those are our case managers, our community health workers. And so I tend to tell our teams to lean into those spaces. We actually have a program called Odyssey, the journey of becoming a doctor at Novant. And we call it Practice Foundations, where we talk about health equity. We talk about the fact that our goal is for everyone to have the best level of care, and it's going to take different resources for different people to make sure that they get there. And so we actually kind of create that understanding early in careers at Novant and then share with them what the resources are for people to be able to provide that culturally and linguistically appropriate care.
Now, it sounds to me like you were very focused on some of these goals, and to do so, I imagine you decided you had to sort of go beyond the bedside and cull some of these resources together at a larger scale. Can you talk a little bit to us about what it's like to move from sort of the ICU to the C-suite, and how, if one's interested in doing that, where did you get started, and how should others approach that path? Because there are not many neurointensivists that I know that have taken that path.
So when I left Hopkins and joined Novant Health back in 2004, I came as the medical director for stroke and neurocritical care. And often my colleagues go into neurocritical care and they're not necessarily in a leadership role. So part of my responsibility was to be able to understand the full landscape of the experience of patients, including what happens in the community, what happens within the hospital as well. For those who are in leadership roles or not in leadership roles, one of the best ways to understand what's going on in the community and to get those networks, because community partners are critical to this work, is you can join boards for community organizations. If you're not interested in joining boards within your own hospital or healthcare system, there's typically initiatives and work that's going on. I always say be a lifetime learner. Most of these committees and advisory councils are very interested in our clinical insights. But when I go to those advisory councils, I'm also learning about operations and finance and the other roles and responsibilities of the people around the table. I actually take stretch assignments where it's not just about clinical outcomes, it's about operations or it's about community engagement so that you can learn some of those components that it takes to sort of build that career in leadership. And honestly, it's like medical school again. You get to try different areas of medicine to see what you like. So neurointensivists can go into information systems. I have a colleague who's an OBGYN and she leads a lot of our information system work, Dr. Noelle Clark. It really does depend on what's interesting to you in leadership, but the only way to know it is to become involved in some of that work and advisory councils and committees in healthcare systems to see the sort of the underbelly of healthcare and where there are opportunities for you to spread your wings in that leadership capacity.
Now, a lot of institutions have developed some healthcare leadership training programs, or there's institutions with advanced degrees in healthcare leadership. Where do you see those in the role of preparing people for the kind of work that you're doing?
So I'm a little bit of a non-traditional student in ways. So I took time off after getting my human biology degree at Brown University and tried to make money for the next step in my education to help pay for it. And so I sold insurance for the commission. So the harder you work, the more money you make. That was absolutely right up my alley.
Hmm.
And then I worked for McDonald's and ultimately, in a very short period of time, got promoted to what they called market recruiter. There were only two on the East Coast. It was around understanding operations, finance,
Mm.
and really the culture of the organization. McMaster's program for those who had neurodiverse challenges, McSenior programs. And where I learned to be a leader, honestly, was there. But I also learned that I loved business. So I made the decision to get my master's in health, finance, and management at the Bloomberg School at Hopkins School of Public Health. I don't think it's required, but that particular degree program gave me an administrative residency where I worked with the leader for the Hopkins medical group and got exposure to operations and finance in the ambulatory setting. Most of my colleagues now are in two schools. They either are returning to school and getting master levels degrees, or they're doing those stretch assignments where they're learning about operations and finance. It isn't required to get a higher level degree. I think it depends on if you are one of those life learners that can pick up the skills along the way, or if you're someone who wants more foundational education before moving into those leadership roles.
Got it. And I'm curious, where we've just completed our match here, and we've interviewed a lot of candidates, and there tend to be some trends in the way that people going to neurocritical care sort of act and think. So one of the characteristics I hear that people choose the field is because they like to see how they make small changes to physiology. Maybe they adjust the mean arterial pressure, and they immediately see a response in the patient. That's really gratifying. That's one of the reasons they go into neurocritical care. Some people tell me. I'm wondering, from your perspective, what are some of the characteristics maybe in common between what what's successful in the neuro ICU and what works at the sort of larger systems level? And maybe what are some areas where neurointensivists might be more challenged to see and affect change across systems?
So it's interesting, as intensivists, we experience the fact that you cannot be successful without a team, perhaps more than some other colleagues who work independently in an outpatient setting, for instance. So it's clearly characteristics for both ICU and leadership are collaboration, accountability, being outcomes driven. I think it's also that kind of dynamic personality, like you want to be a problem solver, nothing more than healthcare to give you opportunities for that. Being accustomed and willing for change, because it's never going to be quite the same. So I think some of the things that I lean into are the fact, well, in my clinical life, things change constantly and things are unexpected. Pretty much true in my leadership experience as well. I think you build a resiliency over time. I have been told that intensivists like things to happen quickly. So, if you're in the middle of an urgent situation, no one should be strolling to the bedside. So I do think you have to toggle that back a little bit because in leadership, sometimes it takes that consensus building and collaboration that's a little bit different from we need to make an immediate decision now. We don't have until next week to think through it. I also think that some of the more major leadership decisions that I've made, if I was too quick to make the decision, there's a fail forward that's important because you can't be so collaborative that you never get anything done. Paralysis by perfection, all of those things don't necessarily work in leadership. And I I feel like that's maybe where it's a little bit different, is that there's a little bit more time, thought, collaboration that happens when you're building major programs that are system wide. And it's a little bit of a different skill set than you learn when things happen pretty quickly in a critical care space.
Great. Well, I would love to hear from you, and I think our listeners would too. Or what are some of the programs or experiences that you're either really proud of or that you're really excited about as you kind of work on this major challenge of building health equity?
Well, it's interesting. I think it ties into where does a neurointensivist find their way into leadership. So it often surprises people that after several leadership roles in stroke and neurocritical care, I became the senior vice president for women's health and wellness for Novant Health System. And people would say, why is the neurologist doing women's health? It wasn't OBGYN. I think we often think about OBGYN and women's health, but the way we thought about it as a system was any primary care or any specialty service line, how do we make sure that the outcomes for women are equal to the outcomes for other patients? How do we make sure that the patient experience is the same? So one of my first efforts is kind of the inaugural look at healthcare from a dimension of diversity was that role. So even beginning to gather the data in a way where we could answer those questions was important. It was the foundation for the role that I do now, where we look at many dimensions of diversity, geography, social drivers of health, gender, and we want to understand, are we providing the highest level of safety and quality consistently for every single patient? And I think that work has spanned in the years that I've been in this role, both on the inpatient side and outpatient side. We've looked at things like sepsis outcomes, mortality. We've looked at congestive heart failure, readmission, and return to the emergency department, colonoscopy, and whether or not people are getting their colorectal cancer screenings and mammography. So we've woven into both acute care settings and ambulatory settings the opportunity to look at all of our patients. And one of the things that I say is let's start with the total patient population. Let's see if we're reaching that level of excellence that we expect of ourselves as an organization. If we are, then we'll continue to pursue that level of excellence while we look at who have we left behind and make sure that all of the patients that are undergoing that particular service have that same outcome and same experience. So it's a balance of continuing excellence for the total population across any of the care that we provide, inpatient or outpatient. My favorite, I have to say, was my work with stroke elimination. So we applied for an NIH grant many years ago to get out into the communities, educate people, know your numbers, help them to understand what their risk factors were. It is now what people look at as the foundation for our community health services. We still continue to go into the community. Full circle, that team now reports to me. So it's been an amazing journey to watch it kind of grow up over time. And that I think has been some of the most impactful because those disease processes become chronic if not identified early, and then lead to a lot of illness that creates challenges for our communities to stay healthy.
Yeah, you mentioned that program was funded by the NIH, and so many of our colleagues have lost NIH funding for similar programs recently. I'm sure it's affected your work as well, and I imagine you've thought a lot about this. What are some of the strategies that you've employed to keep up the momentum on this work in the current political climate?
So one of the things that I'll tell you the way I talk to my team. So nothing about today's political climate changes what we do. I think part of that is the way our program is designed. And we have been very intentional about not focusing care on any particular group of people. It's always been about the total patient population. We also cannot unsee the fact that there are patients that are less likely to achieve that highest level of wellness and health for a myriad of reasons. So we will, one by one, individualize and personalize care to address that. Where there is less funding, we are looking at more innovative and creative ways to work together. I have colleagues who have experienced and community partners who have experienced shifts in funding. But I'll tell you, I think it's if you're in healthcare long enough, and I've been in it a couple of decades, people are really focused on what's happening today. But there have been changes throughout the history of my experience of healthcare. And we have been innovative, we've been creative, and most importantly, we've been very patient-centric. So we'll continue to do the hard work of making sure that we're not just focused on any particular patient population, but every patient has the opportunity to achieve that wellness, which, by the way, is harder work, I realize, than taking one patient population at a time and trying to fix it here and then going to the next patient population. But what sometimes happens when you go population to population is if you take your eye off of the total population, those people who were achieving excellent outcomes somehow get impacted. So if you shift resources from place to place, then you just create problems while fixing problems. So I think one of the challenges of this work is ensuring that if patients were having excellent outcomes to begin with, let's keep them there while we continue to understand why there may be clinical gaps and how do we get everyone to achieve that highest level of wellness. It's a deeper intentionality, more investment and commitment, but I think it's the right approach. So in a lot of ways, we haven't changed our strategy or our approach, but I do understand if there isn't that level of system commitment like at Novant Health, people have had to pick and choose populations, and now that makes it difficult.
That's really interesting, and I'm just picking up on something that I want to ask you about. You're often using the word wellness in addition to health or health or in place of health, and I don't know too many neurointensivists that think about their patients' outcomes in terms of wellness. Can you is that intentional? And can you, if so, can you talk a little bit more about that?
I think so yes, it is intentional. One of the things that, and we talked about it a little bit earlier as we joined the podcast, when we think about outcomes, as neurointensivists, we're very outcomes driven. but our experience of outcomes, health and wellness, is that 20%. It's what we do in the medical venue of care. Wellness has to do with someone's health literacy, someone's ability to be able to get to their primary care doctor, someone's ability to be able to have a sustainable source of nutritional food. There is more to the whole person, the whole patient. So health is what we do in healthcare systems. It's what we do in intensive care units, but overall wellness has to do with social isolation or connection to people. It has to do with resources. I think that's the bigger picture. So when I talk about outcomes, I think of them in terms of all the great work, and it is great work that we do in medical venues of care. When I talk about wellness, it cannot only be done by healthcare systems. It has to also include community partners that look at the whole person or the whole family that struggles to attain that highest level of health and wellness.
That's great. That's very well put, and I think hopefully will inspire a lot of people to think a little bit more about what we're trying to achieve when our patients, graduate from the ICU. What comes next? I'm really interested in this idea, as you mentioned, of looking at the whole population and really focusing on. It sounds sort of like an approach of, the rising tide lifts all ships, um, and yet, a lot of work in the health equity space has been in finding target populations and trying to understand the cultural and specific, institutions that are affecting their outcomes and also may be targeted to improve those outcomes. So I'm wondering, like, how do you balance that? I'm thinking some of the New England Journal paper on blood pressure management through barbershops and in the Black communities, and how are those initiatives different from what you're talking about, and how are they the same?
I don't think they're different at all. I think we're talking about individualized and personalized care. So barbershop initiatives are a great example. There are some people that don't go to barbershops. They do their own hair at home or they do their own haircuts at home. So it can't be, we're going to solve the problem of blood pressure for the Black community by creating barbershop programs only. It's one of many things that we do for all communities. One of the things that inspires me is that sometimes we are very different and sometimes we are the same. So my boys are soccer players, and all of them are trying to wear the exact same hairdo right now from completely different walks of life. So I think that what we have to realize is things like race and ethnicity, how I experience being Black in America may be something very different by how someone else experiences it. My resources may be different. And so creating programs that are focused on a dimension of diversity instead of individuality sometimes gets us caught in a little bit of a challenge because what we're creating doesn't necessarily apply to everyone. And then sometimes assumptions are made. One of the projects that we worked on was mammography, and across the country, often African American women do not get their mammograms as often as Caucasian women. At Novant Health, they get their mammograms at the same rate. It was some of our faster growing populations, Asian women and Latinas, who were less likely to get their mammograms. We insisted on keeping that level of excellence for our white women and our Black women while we understood better what might be some of the cultural and linguistic challenges for the populations that were not getting their mammograms, and then increase the numbers for everyone. So it is a yes and. There we have unique cultures that feel differently about healthcare. They either trust it implicitly or mistrust it completely. And we have to just meet people where they are. So it's not different from how people think about it. I think what's important is focusing on the total patient population because ideally everyone has that level of excellence. And what we want to be able to do is understand where there are clinical gaps, what creates those gaps, how might we be able to partner with our patients, help them be advocates for themselves in order to be along that journey that lets them get to where everyone should get to in terms of their health outcomes.
Great. When you talk, you have such a can-do attitude behind all of this. What keeps you so optimistic about the future of health equity and neurocritical care and beyond?
Well, the name of your podcast isn't Tell a Lie, so I won't I won't start there. There are times when it's hard. It's hard work. You're in the middle of an ocean with a teaspoon for an oar, and you do have to start somewhere. And I think you can be overwhelmed by the amount of opportunities there are to get every human being on the planet as healthy as they can be. So you can't start with something so big. You start with your region, you start with your hospital, you start with your patient population. One of the things that inspires me is my team, who are often out in the communities working with patients who start with no resources at all. And one by one, they tick away at each of the challenges. And then you see them going from being a patient who comes to the hospital 12 times in a year, 12 times in 3 months, to having primary care, having a bus pass, having food. I get inspired by each individual success story because if you wait on the global, everybody is good success story, you won't find inspiration. So my team inspires me. They are tenacious, they are compassionate. They know that the patient is at the center, and they hear a lot of the same things that everyone hears right now. And they remain inspired because they see every day how their efforts make an impact on the communities and the patients that we care for.
Great. Well, now I'm inspired. I think celebrating those wins is so important and really does keep us going. We finished the podcast with just some quick hit questions to kind of get to know you a little bit more. Do you have any passions or hobbies, outside of your both clinical and administrative roles?
Yes, so I mentioned it. I have twin boy. Maybe I didn't mention I have twin boys who are 10 and they play soccer. So I am a soccer mom. That's probably my most important identity at the moment. At the moment. So I enjoy the road trips. I enjoy the connection of family when you're a busy physician, executive, mother, wife. I wish I could say that the schedule allows for family dinners every night, but it doesn't. So being on the road, sometimes it's not the best food. It's what we can get and eat along the way, but it's that travel time. I enjoy my husband very much and traveling with him and with our children. I love my community board work because it takes me into the community and it feels very impactful. I don't have a long list of other hobbies because I don't have time, but those are the things that fill my cup.
And can you complete the following sentences? So my purpose is,
So I think my purpose is to be a role model, to be the best physician, executive, mom, wife I can be, because I wear many hats. I know that I have had leaders come to me and say thank you for the times that I said, I'm going to have to leave this meeting because I'm going to a parent-teacher meeting, or I'm going to just spend time with my children. So I want to role model what it looks like. I don't always have the best work-life balance, but I want to make sure that I create space for people to have it.
great. I recharge by,
Let's see, yelling and screaming at soccer games is very cathartic. And enjoying, that's another village of people that are completely different from my clinical life. So I love my soccer village, the parents and the families that are there. We travel together all the time. And, I come back from weekends feeling recharged, perhaps because we haven't talked about healthcare for an
yeah.
entire weekend.
I love,
My faith, my family, the privilege of being a physician, which is a lifetime honor that I hope my children have one day.
and lastly, or no, almost lastly, I want to be remembered for.
I want to be remembered for my impact on the community. I want to be thought of as a strategic thinker that regardless of what decade she practiced in and designed programs for the community, She was an innovative pioneer who made a difference working alongside community members to ensure that every human being has the opportunity to have their birthright, which is good health.
And now, lastly, what advice would you give to the fellow about to graduate?
I would say don't consider your graduation your last moment for education. I think being a lifetime learner, and it's hard because it's not just about neurocritical care and science, it's about you as a person, you as a leader, being open to ideas for what your career could look like. Retiring at the bedside is amazing, and you should do that if that's what you want. But if you find yourself being pulled to be a leader and you can be satisfied with impacting healthcare without necessarily doing it patient facing, I invite people to consider some form of that transition into that space because we need critical thinkers, and that is what neurocritical care docs are. And I think it would be important to have representation and leadership.
Dr. Gregory, thank you so much for joining us on the podcast. This has been an absolute pleasure, and I'm leaving here inspired. And this recharges me, these conversations with people like you. So thank you so much.
Thank you. I really appreciate the time together.
This has been the Neurocritical Care Society podcast Perspective series. Please subscribe wherever you get your podcasts and tune in next time.